Good afternoon. I am indebted to organizers of this meeting for allowing me to present the data that I am going to address, which are the barriers to access to HSCT from an international perspective. I do not have conflicts of interest, and I am going to address initially the identification of the problem and then possible solutions. The problem stems from very many sources: patient, the referring physician, and the bone marrow transplantation program. As far as the patient is concerned, there are data about the importance of age and gender, race and ethnicity, socioeconomic status, insurance coverage, education level, health literacy, cultural preferences, religion, and other disparity factors. As far as the referring physician is concerned, there's data about the knowledge of the referring physician, perceptions about the usefulness of HSCT, experience with HSCT, conflicts of interest, and other biases. And then as far as the program, HSCT program is concerned, there's cost. The cost item is critical in developing countries, in low and middle income countries. Donor, comorbidities and frailty, disease status, caregiver availability, distance, center expertise, and capacity barriers. So this is a picture of the world in the night. The more enlightened areas are the areas that have more money. This is sad. As you can see, there are a lot of areas in which there is no light, and which means that there is no money. So light is related to money. And see, the distribution of the centers participating in the CIBMTR is about the same as the distribution of the light in the world. So HSCT is a money problem as well. And there are published data which indicate that in Mexico we are grafting only 5% of the persons who need an HSCT. And where is the rest of the patients that do not get an HSCT? Unfortunately, there. Now, I will address some possible solutions. I have to say that I am addressing this from an international perspective. Since I live in a middle-income country, it's a perspective from that point of view. I will address data of a domestic experience along a 30-year period. And for all these reasons, I fully recognize that the data that I am going to present to you are biased. I spent some time at the Mayo Clinic in 1982, and I met there Professor Clark Hoagland, recently deceased, who was by then the chief of the bone marrow transplantation unit of the Mayo Clinic in Rochester. When I came back in 1983 to my hometown, I decided I had two choices: either try to reproduce the methods which I had seen at Mayo Clinic or develop a totally different methods. So I decided not to reproduce others' experiences. I decided not to be a copycat and develop our own program, and then identify and break dogmata in the area of stem cell transplantation, and obviously engaging in teamwork. This figure here refers to the transplant that we have done at Clinical Ruiz since 1993 to 2022. As you can see, the number is by now 1,616, and I will address some of the points that I have learned from here. The main indications in our clinic for allogeneic bone marrow transplantation is acute leukemia, whereas the main indication for autologous transplant is multiple sclerosis. Recently, I was invited to write this contribution for Lancet Hematology, Lessons learned starting a bone marrow transplantation program in a resource-constrained setting. And I will address some of the points which I described in that particular paper. So the recommendations are here. Start with autologous transplants, then move into autoimmune diseases, go into allogeneic transplantations on an outpatient basis, do not graft cord blood cells, use generic drugs and biosimilars, and do not irradiate blood products. And I will try to elaborate on these points. Start with autologous transplants. Autologous transplants, specifically in multiple myeloma, I think that they are the easiest one. They can also be done in lymphoma. You don't need a cell-freezing unit to start a bone marrow transplantation program. You can employ non-frozen cells using short preparative schedules. And high-dose melphalan can be employed both in myeloma and lymphoma, which is very convenient because it is delivered in a single day, and do the transplant always on an outpatient basis. This is the schedule that we use for auto transplants, both in lymphoma and myeloma. It can be used also in some other malignant conditions. When we had a 10-year experience, we made this publication, and in a collaborative study with physicians from Mexico and some other Latin American countries belonging to the Latin American bone marrow transplantation group, we made this publication in which we proved that freezing the graft is not necessary for all transplants. And we strongly feel that the big freeze is not necessary now in the practice of auto transplants, specifically in myeloma. Now, we recently published this information about high-dose melphalan being used both in lymphoma and in myeloma. And as you can see, if you compare this with the beam-based regimens, in our experience, the results are about the same. So melphalan 200 can be employed successfully in lymphoma. This is the price of a 50 milligram vial of melphalan. As you can see, in Spain, it's very cheap, $67, and in the United States, it's substantially more expensive. So in places in which melphalan is affordable, this is a great choice to graft patients with lymphoma. Why are the drugs so costly? Well, there are some suggestions about the government trying to regulate this, but these type of things in low and middle income countries do not work. Then once you have gained experience in auto transplants in lymphoma and myeloma, you can move into autoimmunity. Multiple sclerosis is a disease which is treatable with hematopoietic stem cell transplantation. There are some other ones, but the largest experience is with multiple sclerosis. We have grafted 1,194 patients with multiple sclerosis using this approach in which we use cyclophosphamide 200 milligrams per kilo in 4 doses, and at the end of the transplant we employ rituximab. This is the places that we have grafted patients from coming into our program, and we have data proving that around 80% of patients do have some response in the different types of multiple sclerosis. Obviously, the best results are obtained in relapsing remitting multiple sclerosis. We did this feasibility study with 281 patients, then safety study with 426 patients, and this is an efficacy study in 617 patients. And finally, this is a paper that we just published about 1,000 transplants for patients with multiple sclerosis. As you can see, the usefulness of all the hematopoietic stem cell transplantations programs all over the world in multiple sclerosis are substantially better than any of the drugs that are employed in the disease. Our method that uses the 4 doses of cyclophosphamide split in 2 blocks apart is less nephrotoxic and less cardiotoxic than the conventional methods to graft patients with multiple sclerosis by splitting the total dose of cyclophosphamide. Well, as far as allotransplant is concerned, I don't think that it is necessary a bone marrow transplantation unit. HEPA filtered rooms are not necessary. Laminar flow rooms are not necessary. And then if you have money, devote those funds to laboratory and drugs, not to build a BMT unit. Do the transplants on an outpatient basis. Employ initially reduced intensity conditioning, and together with Professor Gomez Almaguer in Monterrey and his group, we made this paper in 2000 in which we described the first 4 patients that were transplanted fully on an outpatient basis using a non-myeloablative procedure. This is the method that we employ, employing affordable drugs, busulfan, cyclophosphamide, fludarabine, cyclosporin A, and methotrexate. We recently made this review in which we analyzed the experience not only in our country, but also in other countries, conducting allotransplants on an outpatient basis. This is the indications of allos in our clinic. The main indication is acute leukemia. And I think that alternative donors are to be considered in low and middle income countries. We have shown and published that domestic cords, the one that we get in Mexico, are suboptimal. They do not engraft. Imported cords are extremely expensive. Cord blood banks are in the way of dying, I feel. Matchedon-related donors are extremely expensive. BDMatch is helping with some of the expenses of the matched-related donors, but still they are expensive. And I think that haplos are the solution, employing reduced intensity condition. As you know, haplos are being done all over the world with excellent results. We have published our experience comparing haplos versus cords. In Mexico, haplos are cheaper if you use cyclophosphamide. Cord blood banks are decaying. Haplos are more realistic in underprivileged circumstances, and we can do the haplos without a hospital on an outpatient basis. We have already published. So the Clinimax versus post-transplant cyclophosphamide, obviously for low and middle income countries, cyclophosphamide is better. This is the protocol that we employ for haplo-HSCT on an outpatient basis, both in Monterrey with Professor Gomez Almaguer and myself. And cyclophosphamide is delivered in days +3 and days +4. And now, what about post-transplant cyclophosphamide? Usually, the dose is 50 milligrams per kilo, but you can cut it down to 25 milligrams per kilo. This is less toxic and equally effective. So this is something that we should think about, lowering the post-transplant cyclophosphamide dose, and this is enough to prevent severe acute graft versus host disease. As you can see, the prevalence of 50 versus 25 milligrams is about the same. And as has been shown by the group of Dr. Gomez Almaguer and myself, we can do this in children using post-transplant cyclophosphamide on an outpatient basis. The results of cords versus haplos in Mexico are about the same. And we feel that this is the solution to the lack of an HLA-compatible donor. Dr. Gomez Almaguer recently published this experience with 60 patients with, that were transplanted on an outpatient basis with haploidentical drugs, and we also added this experience in which we have proven that haplos can be done on an outpatient basis. Then the following recommendation is to employ generics and biosimilars. Genetic filgrastim works the same as the originator, the Mexican filgrastim. We made this paper some time ago, and also Dr. Gomez Almaguer and his group analyzed the efficacy of 3 filgrastim intended copies, they work the same. And also in Monterrey, they have shown that 50% of the dose of plerixafor is useful to mobilize a patient in which GCSF is not enough. Do not irradiate blood products. White blood cell filters are enough. This machine, which is costly, is not strictly necessary. Dr. Gómez Almaguer published this experience in which he analyzed the graft versus host disease prevalence after irradiated or non-irradiated blood products, and he showed that it's the same, so you don't need to irradiate the products, and that also translates in reduced costs. So, trying to, another point that has been important for us is publishing our experience, and since our first paper published in 1993 about this transplant, and the most recent one recently published about 2 weeks ago, we have done a total of 166 papers. In conclusion, these are my suggestions to try to make easy the stem cell transplantation procedure in low and middle income countries. Start with AROS, specifically with myeloma. Do not build a BMT unit. Outpatient conduction is feasible for both AROS and ALOS. Jump into autoimmune conditions. Use non-frozen cells. You don't need a freezer. Then move into ALOS, employing initially reduced intensity conditioning. Do not start a cord blood bank. You will not be able to support it a long time. Do not use cord blood cells. They don't work. The domestic ones and the ones coming from abroad are extremely expensive. Stay away from matched unrelated donors, only in very specific conditions. Moving to APLOS using post-transplant cyclophosphamide and doing them on an outpatient basis. Do not buy the Clinimax. Employ domestic biosimilars, they work the same. Avoid the irradiation of products. Do not buy an irradiation machine, and if you don't know what to do, ask your wife. And my wife is here, so I ask her, yes. So, as a summary, I will try to highlight some of the salient features of the Mexican methods that Professor Gómez Almaguer in Monterrey and myself have done. They cure about the same proportion of patients. They are not simple ways to allograft. They need strong laboratory support. They do not require special BMT units, can be conducted on an outpatient basis. Even HAPLOS, as I have shown, are substantially cheaper, and this has resulted in more patients grafted, more patients cured, more papers published, better physician education, and better health care. And I end up this lecture with a picture of my family, my wife, my 3 sons, and my 7 grandchildren. I dedicate to this presentation because they always support me in staying out from home and doing things like this one. Again, I very much appreciate the invitation of the society to present this data for you, and I also thank the attention of all of you. Thank you very much.
I think you did it. We actually went back in time. That's wonderful. Adrian, come on up. All right, at this time, we'd love to take some questions from the audience.